Today we're going to talk about perioperative care. It's mostly risk reduction questions that you see. So I'm just going to give you brief information about it, then we do some questions. But this is an area you have to know is very important for your test, especially risk reduction. Most of the questions about risk reduction in perioperative, you want to prevent harm to the patient. You want to make sure you can identify things that will make the patient sick. And then if there's emergency, how do you take care of it? So that's the key aspect of this area. Briefly, the stages is divided into three, right? So there's phases. So um, I'll just give you a quick note. Perioperative phases is three. There's three of them. One of the first phase is basically, we call it pre-op, before surgery. And what usually you are involved in is to make assessment. This is where the nurse do the assessment and see how the patient is doing. They make sure that informed consent is signed, everything is, and then educate the patient if they have any issues. And then prepare the patient, right? Prepare. You're preparing the patient. This is like where you put the patient MPO and make sure they have bowel prep or anything like that. So that's the first stage. The second stage is usually intra-op. You are not involved, but you have to know what um, you basically delegate your function to another nurse who is an intra-op nurse. And so that's what she's do. They're making sure this asepsis is taken care of, patient positioning. So I'm giving you key facts. You don't have to like read so many book, watch a long video. This is the key, and you use it to answer the question. That's what your body is going to ask you, like the most important information, and you're going to focus on it. So intraopness is job is make sure there's a sepsis going on. Patient is positioned and the surgical side is not contaminated, right? Or if there's any complication, they're watching for any complication, monitoring for complication. So that is what's usually happen. Then post-op is usually the third phase, post-operative, that's what we call it. And this is where PACU, patient is the PACU, post-anesthesia care unit. And there's a lot of things that can happen, right? You want to make sure you're watching for complication. Pain management, usually, okay, yeah, watching for complication um, and anesthesia effect on the patient. These three things, if you know when they ask you the question, that is what you're looking for in the answers. You're looking for all these information. Say, hey, this is patient in post-op. I got to check for anesthesia complication, watching for complication, managing the patient pay and making sure everything okay before they go to the ward. That's why we call it peri-operative, around the operative situation. The key fact for your NCLEX, I would just put here. So the concept basically that you have to pay attention to is, I would just summarize it. Number one, informed consent. Make sure it's signed and make sure you patient receive indication education. And remember, this has to be voluntary. So when a patient asks you a question that is detailed related to surgery, you're supposed to let the doctor know. Um, then the pre-op, where you check labs. This is where you check labs, make sure everything okay. You educate the patient. Your surgical site is marked if it need to be marked. Then aseptic to prevent infection, right? And then complication. That is all. And you see how this is all risk reduction. I make a video about how risk reduction is the basis of your NCLEX. When we say safety, that's what we mean. It's a safety exams is based on risk reduction, right? First, you have to know that there is a risk. So you make preparation for risks not to occur. That's the first thing. So you're preparing the patient. Secondly, Then when the risks happen, you want to intervene quickly, right? You want to intervene quickly. So that's what they say. What do you do first? What do you do next? Then the last one is the emergency one. It's already okay. What are you going to do to fix it? So every question, every subject area that you study, think about that way. I'm doing Addison disease. What is it? What can I do to prevent this patient from getting sick from Addison? If it happened, how can I identify it? Right? Those are select or apply, they put it together. Then when it happened, how can I fix it? Treatment of the patient. And then you know the content related to that. There's no question they'll ask you if you think that way. Every question, think about risk reduction based on the pathophysiology of the disease. So this is brief, lecture on that. And then let's see if we can apply that information. I don't put so many things here to confuse you. And first thing you do, who should be assessed first? Of course, it's prioritization. I saw you. Now complication has happened. What do you do? This is our perioperative patient. And then receives the following report on 4 postoperative patient. They all had surgery, right? Postoperative say, client. Which of these do you think is in trouble and you have to see them? They all have problem. First, you know how to do prioritization. You have to be sharp. You got to make sure you're picking answers, those that are really, really sick, breathing, shock, sepsis, airway, and then analyze it. Don't jump the gun. Don't say, I see something, I feel comfortable, and I pick it. Stay away from it. Be careful. Okay. Like I said, I tell you, divide the thing into two, right? A client that's what 50 ml serosanguinous. If this patient is bleeding, they will tell you it's bleeding. Serosanguinous is just a drainage, like a Kool-Aid like drainage in the wound. Patient just had surgery. Do you expect that? You got to be sharp, not expect it. I expect the incision to have some drainage on it. 50 cc is some tiny, right? The client with decreased breath sounds and oxygen saturation that I don't like it, right? It's saturation, yes, breath sounds decreased, saturation 91. I expect it to have athleticism, but now this athleticism is affecting the client function, right? Sat 91 and the breath sound is decreased. If I want you to worry about athleticism, I would say at the long basis, watch for that. Always watch for, you got to be flexible. If they say at long basis, that means if this is your long, it's at the base, which is what is a true athleticism. But this is, they said, decreased breath sound. They did not say at the long basis. That should tell you, I want you to worry about it. The client report nausea and requesting antiemetic. Well, do you have time to deal with this problem? Think about it. The client requesting assistant ambulating to the bathroom. So based on that, you can see that everybody have a problem. I want to walk. I am nausea. I have nausea. I have decreased breath sound, and there's some drainage in my wound. If you are being sharp, you can see that B is dangerous. He has no time. You have 1 second. I will see the first one first. Then later on, check the guy with the wound and see if it's okay. Sometimes C can be dangerous. You have to look if they have nausea, are they going to vomit and aspirate? But they don't, I did not, you don't want to think double, right? This is all I give you. So deal with it. Don't overthink it. If I want you to worry about aspiration, I will put something there for you to overthink it. So this is the way I want you to think about prioritization. And this is as you can see, this is the right answer, right? So I just give you a few explanations. So same thing. Remember, we're doing perioperative, so you got to go for the buzzword. In every question, there's always one word that will take you to the your answer choice. I call them buzzword. Read the question at the back. What is the next priority action? That means you have to take every options over the appropriate, but they are not a priority. Once again, every action is appropriate. If you pick this and you get it wrong, it's fine, except you are ignoring the fact that the question said priority, right? So, and the buzzword here is priority, and it's a client undergoing surgery. That's the key. Don't forget that patient undergoing surgery means patient is having surgery right now. All of a sudden, it's tachycardic, muscle rigidity, and rising temperature. Those are three buzzwords. You know what it means. If I tell you a patient has tachycardia, muscle rigidity, temperature high, and is having surgery, there's only one thing that can cause that. And that one thing, bring your content. And when you know about it, look at the answer choice and say, hey, what would I do? Do I call notify the surgeon of suspected infection? Do you think this is an infection? Administer dantrolene and cool the patient. Stop the procedure and prepare for defibrillation. Administer muscle relaxant and sedation. Think about it. I told you risk management. The complication has occurred. What can you do to prevent risks? You have to bring your content, right? Tachycardia, muscle rigidity, and temperature. If you have infection, you're not going to have muscle rigidity. That should tell you this is not infection. Secondly, why did I say undergoing surgery? That's the buzzword. Should give you answer. If you have infection, tachycardia, and temperature will happen, but no muscle rigidity. Anybody who is having surgery and all of a sudden he has tachycardia, muscle rigidity, and increased temperature, this is what we call malignant hyperthermia. This patient has MH. Then you go, how do you treat MH? Malignant hyperthermia. So tachycardia, muscle rigidity, temperature high, and I'm having surgery or it happened in the PACU, malignant hyperthermia. So think about it now. Based on that, suspected infection is gone. Test taking strategy, right? Dantrolene and choline. Even if you don't know, one said give the patient medication and cool them. If I cool you, I will help with your temperature. So that may be the right answer, right? Stop the procedure and defibrillation. We stop the procedure, but we don't need to defibrillate. I did not tell you the patient is in VFib. You see how you don't fall for some answers that doesn't answer the question. Is the trap, like defibrillation. But you know this patient, if he's malignant hyperthermia, is not in VFib right now. The muscle relaxant is there to trap you with rigidity, but it's not going to take care of the tachycardia and temperature. At the same time, I don't need to sedate you anymore. This is what malignant hyperthermia. Based on the way I've gone through each answer choice, that's what you do. You know that cooling will help with the temperature, and dantrolene will help with the muscle rigidity. It's due to patient maybe have genetic disease that is related to that, and then that may have led to overstimulation. And so this is a calcium, it's a form of calcium channel, channel blockers. It block the release of calcium and relax the muscle. So this is malignant hyperthermia. Every time they give you a question related to perioperative problem, watch for that. This is, and you see muscle rigidity, that's it. So this patient, dantrolene is the treatment, and cool the patient. This patient need to be in ICU. The client is in a PACU. You see, these are post-operative in the PACU, but still perioperative, right? You are in the PACU. It's drowsy, one, but arouses to verbal stimuli. It's drowsy that when you talk to them, they wake up. And has respiratory rate of 10. Is this patient okay to let go? What do you think? Respiratory rate of 10. I don't like it, right? He's drowsy. I don't like it, even though I wake him up. That tell you something is not right. But what happened? He just had surgery. It's probably anesthesia still in the system. That's why I use the word PACU, post anesthesia care unit. So notify anesthesia team immediately. I did not tell you patient in distress. His respiratory rate is low because he's probably is drowsy and he's not breathing. He's in the PACU. And notify anesthesia immediately. There's no emergency here. There's urgency, but there's no emergency. So what are they going to do? They will tell you what you should have done before you call them. That means this patient just had anesthesia, probably still has opiate in the system. Give them naloxone, and they will wake up, and that will increase the respiratory rate. We don't going to continue to assess the patient because his respiratory rate is going down. Placing them in high fowler is not because they have oxygen problem. You see how you can be trapped. Always work with what you give me. I never give you saturation, right? If saturation is going, okay, fine. But I told you it's respiratory rate. His respiratory rate is going down because he's drowsy and still sedated. The first thing you can do, take away the sedation. And so we give them that. We give them naloxone as opiate, right? So client is sedated and we need a reversal agent. Which post-op client should the nurse assess first? Once again, who would you see first? They just had surgery. Think in terms of surgery. You want to prevent morbidity. It's a post-op care patient. So one patient had what? Blood pressure of 90 over 50, heart rate of 117. I know you don't like it. It's not good, right? Client is drowsy and difficult to arouse, and he has shallow breath. Those are bad words. Drowsy, difficult to arouse, and a shallow respiration. No bowel sound for 24 hours after surgery. What do you think? And pain, 9 out of 10. Which one can sense you? Which one you think you got to be sharp? And let me give you the buzzword. 90 over that and respiratory heart rate of 117. Patient is drowsy, difficult to arouse, and shallow breath. No bowel movement in 24 hours, and pain 9 out of 10. And like I said, you got to be sharp. Is it a breathing problem here? Is it electrolyte shock, sepsis, airway, lethargy, and pain? I say pain that does not lose your life, limb, eyesight, you ignore it. Is this pain is going to kill the patient? 9 out of 10, you just had surgery. Think about it. If you have no bowel sounds for and 24 hours after surgery, what do you think? And if I'm drowsy, I'm difficult to arouse, I have shallow breath, what do you think? And the patient who has 90 over 50 at blood pressure and a heart rate of 117, what do you think? Who are you going to pick? Number two is drowsy. The word difficult, you can't wake them up. It's sedated to the point when you stimulate the patient, it's not even waking up. And he has shallow breath. This is the airway problem. No bowel movement is not a problem. And you have 9 out of 10 is surgery we expect, right? I did not say you have peritonitis. There is no peritonitis there, so this cannot be sepsis. So a shock and the airway problem, you can see that B is more dangerous. A may have shock, but B is more dangerous because they're drowsy, you cannot arouse them, and they have shallow breath. You got to protect their airway. So B is more dangerous. So you got to think about it carefully. So this is the patient we see. So this is what I say here. Which post-operative client should the nurse assess first? The same thing. I change it a little bit. A client who has not voided 4 hours after surgery. So no urine output 4 hours after surgery. Think about it. You got to be sharp. Client with the temperature 101.8 and mild incision drainage. Think about it. Client with the blood pressure of 88 over 50 and a heart rate of 115. Think about it. And then a client with fresh, bright red blood saturating this dressing, surgical dressing. Think about it. This is not designed to trap you, but I want you to like get yourself comfortable, right? These are a little straightforward, but you think about it, they can trap you, right? So who? If you've not voided 4 hours after surgery, is your problem. If your temperature 100.8 and then you have drainage from the incision, is it a problem? If your blood pressure is 88 over 50 and heart rate of 115, is it a problem? And if you have fresh, bright red bleeding, saturating the surgical site, what do you think? So who will you see? Tell me who is more dangerous. You want to see. Like I said, if you want to learn how to do prioritization, you got to use that. Not an expected finding, right? You can wait for 6 hours. Six hours is the minimum we can wait for you to void. That's why we say Q6. When is the last time you had a BAM and this thing? You void after surgery. So that is acceptable. So this is the expected finding. If your temperature is 100.8 and my incisional drainage, there's a reason why I put my, it's just a surgery. It may be sepsis, but we got to watch you. I have time, right? The client, this patient is hypotensive and his heart rate is 115. This patient is in shock again. But you got to be sharp. Breathing, electrolyte, shock, sepsis, airway, hyperthermia, pain, and that. And then the last patient. Think about it. You don't have, that's why I say read between the lines, take your time. Every word in the question count. Don't jump the gun. Client as what? Fresh. There's a fresh here. Bright, red, bleeding. And the word saturating the surgical incision. This patient has active bleeding. I intentionally said this question. He has active bleeding and the shock patient, possible sepsis, and then you can avoid urinary retention. Who is more dangerous? Active bleeding, fresh, bright, red, bleeding, saturating the surgical incision. Somebody may be in shock. Somebody may have sepsis and die. Who will you spend time with? 1 second. If you have it, who you're going to give it to? Like I said, you got to be sharp. If I'm the nurse, I'm going to see this patient. Active bleeding patient need to be seen. You got to fix the bleeding. She's actively bleeding. There's a fresh blood, is red blood, and it's saturating. It's saturated. When he says saturating, that means like ongoing. It's active bleeding that is saturating the surgical decision. Before we see surgical incision, before we see normal C. So C is the trap, but D is in trouble, fresh blood. So watch for that word. This is active bleeding versus anticipated problem, right? So I can give the shock patient some fluid while I find what is bleeding and what is saturating this patient. So I say fresh blood indicate potential hemorrhage, which is an emergency that can be addressed immediately. C is concerning because they are shocked, but active bleeding demand immediate intervention to stop the source of the bleeding. So that's why this one is a little bit hard. What is the next priority action? This is also one questions they can ask you regarding evisceration and dehiscence. A post-op client report feeling a pop, a popping sensation at the incision and is found to have wound evisceration. So the content related this is the individual, this is the abdomen, there is incision here. All of a sudden felt the pop, and then evisceration means there is bowel outside. The bowel is now outside. What are you going to do for this patient? You have all the options there are appropriate. They may not be completely, but priority always 1 second. Which of this is going to save the individual patient? Is going to save the patient from trouble. Reinforce the wound with the abdominal binder. It's going to compress the dressing, the bowel that is out. Therefore, this is gone. Critical thinking question. If you get it wrong, don't Don't be mad, but I will tell you why. Notify the surgeon immediately, not a bowel choice. Surgeon, hey, somebody is eviscerated, the bowel is out. Apply sterile saline soak dressing over the wound. Yes, to put it on the wound so that the bowel doesn't get dehydrated and get infection. Encourage the client to lay flat and stay calm. What is going to cause ongoing evisceration? This by get the patient being stressed, anxious, and moving around. So if you lay them flat, don't move anymore so that no bowel comes out, and you calm them down. You put the bed in the lowest position. Most of the time, bed in the lowest position. Tell the patient to calm down. Don't move anymore. Lay them flat. Bed in the lowest position. Find some saline gauze, put it on it, and let somebody call the doctor. Calling the doctor is not the right because the time you calling the doctor, more bowel is coming out. The time you're trying to find saline soap gauze over the wound, more bowel is coming out. The best thing, stay put, don't move, lay flat, and be calm, and we take care of it. So this is for you to know the steps associated with that. You can read more about it, but this is the management of evisceration or dehiscence. You want to stop ongoing bowel coming out. If the patient need to be flat completely, relax the abdominal wall, and then the bed in the lowest position. Then you can find gauze that. Otherwise, while you putting gauze on it and they sitting up, yeah, you know happy. Lay flat, come down, and we take care of you. Okay, so I know that one is a trap, but just the content associated with that. What is the next priority action? A client recovering from surgery as absent bowel sounds and report what? Nausea and abdominal discomfort. He had surgery. The buzzwords are what? Absent bowel sounds. I have nausea and abdominal discomfort. Put it together. He had surgery. There's no bowel sound. He has nausea and discomfort. Three words put together, you can figure out what is wrong with the patient. What will be your next step? Do you get more information or you try to intervene? These are the things you have to think about in risk management. This is like the best and the first, right? The same thing. What do you do? I know patient had what absent bowel sound. He said I have nausea, I have discomfort. Do you find more information to get a complete picture or you treat the patient? So, what are you going to do? Encourage the client to walk to help with the bowel so that he can go. Assess for signs of what? Paralytic ileus and notify the surgeon. Give the patient antiemetic because they said they're trying to vomit and reassess in 30 minutes and document the finding and continue to monitor. Continue to monitor is usually not the right answer unless because they give you and say priority action, unless it's sometimes a finding that is normal, then but most of the time you just have to ignore it. If you give an antiemetic, you're just treating the nausea. What about absent bowel sound and discomfort? These sound like because she had surgery, he or she had surgery, look like paralytic aliens. The patient, the doctor may like to know. Walking, yeah, it may promote peristalsis, but you got to figure out, you don't make a diagnosis. This is intervention. You see? So this one, number one, is intervening. It's a walk, it may help, but you don't know what is wrong with the patient. B said, hey, this may be, I know what it is. I says for this may be paralytic ileus, and I let the surgeon know, and he can tell me what intervention we have to do. C is an intervention, right? Prescribing medication. And D is basically doing nothing. We want to do something. In the prioritization, I want to do something. Therefore, this is not This is your right answer, right? This is a question that may trap you. Okay, so I talked about it because it's one of the questions we ask for patient who in a perioperative is very, very important. Which of the following is the most critical? The word is most critical nursing intervention. That means the priority, right? Based on this information. A female client is scheduled for laparoscopic surgery, cholecystectomy. That means removal of a gallbladder. During the perioperative assessment, the client reports that she stopped taking her oral contraception pills 1 week ago. So her birth control, she stopped taking it. Which of this is the most critical? The way to answer this question is the buzzword here. I always tell you how to answer question. Most critical, underline it. That means all these answers may be right, but the one that is dangerous, followed by this. Going to have surgery, and I take a pill and I stop. I stopped the pill before surgery 1 week ago, and I'm going to have surgery. Which one is dangerous? Instruct the client to resume taking a oral contraception after surgery. Assess the client for signs and symptoms of pregnancy. You want to know if she's pregnant. She stopped it 1 week ago. Document the client medication history in the medical record. Inform the surgeon about the client recent discontinuation of oral contraception. What do you think? There's a trap answer there. And the trap answer is right there. You stop your birth control, what do? Everybody would think, hey, you may be pregnant, so let's check your pregnancy test. Wrong answer. Don't do that. The most important is the most critical, that's priority. This is not what I'm worried about right now. I'm worried that if you're going to have surgery, you should just stop it 1 week ago, right? So even if she's pregnant, it's not going to change anything, right? 1 week, you won't know, and there will be no show. We got to do pregnancy test anyway, so it's not most critical, right? Oral contraception, what is the biggest problem with that? Aches. That is your content. Aches is all based on what? Clot. You can have abdominal clot, chest clot, head tract clot, embolize into your lung and everything, right? So you're more likely to have clot. We call it aches. So people who take birth control, they're going to have big surgery. That's most likely to have clot. So I need to know before you develop DVT or PE in your surgery. So in your perioperative form, you should let the doctor know that this patient is on oral contraception and stopped taking it 1 week ago. You're more likely to develop clot with abrupt discontinuation of the medication. If you stop it right away, you're more likely to get it like than weaning yourself off slowly, slowly. So this patient, we should let the doctor know. But fine, it's okay. We're going to check for signs of pregnancy. You may not see it. She's 1 week, right? You may not see anything. The most likely thing she's going to do is do a pregnancy test. So this is the right answer. Let the doctor know about it. Okay. So oral contraception can affect blood clot, blood factors. Abrupt discontinuation of it can slightly increase the risk of DVT, especially in the perioperative. So the surgeon need to be know about it so that we can plan accordingly. And next is teaching a client how to use incentive spirometer. This is another thing you have to know for your test. It's just one word, right? How do you use incentive spirometer? You know how to use incentive spirometer. The thing is designed to increase your lung function. So how can you expand your lung? Think about yourself. So that is all. That's the way I let people think about. How can I make your lung bigger? The idea of incentive spirometer is to help your lung get bigger. Well, if you blow out, your lung gets smaller. So the best way is to blow in, right? That means you suck in. So sucking in, inhale, inhalation is the best way to improve your lung function rather than blowing up, right? So this is the most important thing you have to is the most important portion of the device. You got to tell the patient to inhale deeply throughout, right? You take it in slowly. So, and the C is a trap, right? C is a trap. And I will show you this is why these questions are not tricky. I know people think they're tricky. No. And this is what NCLEX do the same thing. They are not tricky. I told you, like I just said, the machine you suck in. So inhalation, right? You have to inhale to open your lung, right? Right? Right. Or you blowing. Which one is it? In. You got to taking in, right? So that's the thing. So this blowing out. Even though you inhale to keep this in the right position, you don't blow out. So that's why C cannot be. So you inhale it and you keep the pistol at steady position as much as possible. So if you look at the C carefully, you will breeze through and you get it wrong. I say inhale. So you suck in like you're taking a straw and your lung get bigger. Therefore, this is saying the same thing. Exhale, blow out is the same. And this is that. You don't do it once per hour. You do it 10 times an hour. So you know the right answer, right? So this is the way. And the last one, last question, then you guys have a day. What is the next best response? A circulating nurse noticed the sterile field has been contaminated. I told you the perioperative care is three phases: preoperative, intraoperative, and postoperative. Intraoperative, your job is to ensure there's asepsis, positioning, prevent complication, and monitoring for complication. You saw that the sterile field has been contaminated. That means breaking asepsis. You got to make sure you intervene. Otherwise, there will be sepsis. So which answer choice mean you intervene for a breaking um, um, sterility. So continue the procedure. We're not going to do that. Inform the surgical team and re-establish the sterile field. Sound better based on your content, right? I'm not going to document and notify infectious control. It's a waste of time. We got to fix risk reduction. Once again, management is I see it and I intervene so that we don't let the patient get sick. Ask the scribe then to reinforce the contaminated area with the drips. No, we need to re-establish sterility. Covering the area is not enough. You patching it. We want to re-establish sterility. Okay, guys. Thank you for joining us. I will see you guys next week. You can also join us on YouTube's channel or my website, www.adaptandclassreview.com. You can check it. And then there's a Zoom link there on Saturdays, 3 p.m. Eastern Time, or on Wednesdays on YouTube between sometimes 5 o'clock, sometimes 5:30. But take care of yourself and good luck in your exams.